The learning objective for Lesson 3 is to understand the meanings of the criteria in the WHO-UMC system certain category. The certain classification requires the timing of events to be plausible. Plausible is a stronger word than reasonable used in the probable category. It means believable, and for that we need more information than for reasonable. The time to onset should fit in with the known pharmacokinetics of the drug, for example its half-life, or for a type B reaction, the time to mount an observed immune response would be an example. A plausible response to withdrawal would be, for example, a rapid resolution of a type 1 allergic reaction such as urticaria and a longer time for hepatitis. The certain category also requires the event to be a recognized pharmacological phenomenon or a specific observable medical disorder. So what do we mean by a phenomenon? Well, a phenomenon is like the northern lights, the aurora borealis, something you can observe that's the result of an underlying physical and chemical process. A pharmacological phenomenon might be decreased prothrombin with warfarin leading to hemorrhage due to its effect on vitamin K activity, respiratory depression with morphine, or serotonin syndrome manifested as symptoms such as agitation, increased sweating, and myoclonus due to drugs that inhibit serotonin reuptake by its receptors. With a new drug, we may not be aware of all its pharmacological actions. Therefore, an unexpected reaction will rarely be classified as certain. Alternatively, the event should be a specific observable medical disorder. This is an important difference compared with a probable category. To classify a suspected reaction as certain, it needs to be something you can observe or measure. If you have definite evidence of, for example, hepatitis or tendinitis, then that's an observable clinical condition. It's pathological. In contrast, for a probable reaction, symptoms that are not observable, such as headache or abdominal pain, can be included. For the final criteria in the certain category, we say that it is rarely used since a re-challenge is almost always required, and this is often unethical. There are strict criteria for a drug administration to be called a re-challenge. If re-challenge is carried out, the patient should have first recovered from the clinical event on stopping the first suspect drug after the first occurrence. The re-challenge should be with the same drug at the same dose and by the same route. Skin prick testing for allergy is an accepted form of confirmation, although there are false positives. Re-challenge may not be needed for a certain classification in a small number of situations, such as when a cytotoxic drug extravasates and causes tissue damage. Re-challenge may well be dangerous, and the majority of reports that have re-challenge data arise from lack of recognition that an illness following the exposure to the drug previously was an adverse reaction until it happened again, or a lack of a proper record of the previous reaction. Now that we've discussed the probable and certain categories, consider this image. These renal stone images show why the pain of renal colic is so severe as they pass down the ureter. You can see why they are spiky from this microscopic view, showing they are composed of crystals. This patient had a history of renal stone formation. He developed an HIV infection and was treated with antiretroviral agents. He again developed renal stones, but this time, when their composition was examined, they were 80% ritonavir. Take a minute to consider whether you would classify this reaction as certain or probable. I think the patient with renal stones had a certain reaction, even though there was no re-challenge. The renal stones were the observable clinical and pathological condition, and they were mainly composed of the suspect medicine.